Hello, dear friends. It gives me great pleasure to be here with all of you in this joint session of the European Atherosclerotic Society and the Lipidization of India. And I'd like to thank the organizers, Dr. Raman Puri and others, for giving me an opportunity. I will be taking you through the statin intolerance over the next 15 minutes to you. I'll start with this great saying by Eugene Braunwald in the 2019 European Society of Cardiology, where he said, atherosclerotic cardiovascular disease remains the #1 cause of death and disability in adults. And elevated LDL-C is the most important risk factor for the development or progression of atherosclerotic cardiovascular disease. Now, with this as the background, lowering 1 millimole of LDL cholesterol by about, let's say, 39-40 has significant reduction in cardiovascular events and also in mortality. But some people don't take it. So basically, what is statin intolerance? The simplest definition is that statin intolerance is the inability to take statins to achieve goal LDL cholesterol, either because of adverse effects or elevation of enzymes. Now, how often does it happen? In primary prevention, it is about 47%, while in secondary prevention, it's about 41%. But interestingly, 72% restarted the statins in primary and 75% restarted it. So that is a pretty good figure to see. Now, what are the commonest causes of stopping these statins? 62% of these patients who stopped statins were actually due to side effects, and 17%, which might interest us in India, is because of the cost-related factors. This is based on an internet cross-sectional study called the usage survey. Now, once this has happened, what happens between the high adherence patients and the statin intolerant patient? You will see that if the patient is adherent, there is a 50% lower risk, or if you are intolerant, there's a 50% higher risk of recurrent myocardial infarction and a 51% increased risk of coronary artery disease. What about the mortality? Lower the statin adherence, higher the mortality. So the statin adherence is also related to mortality. So different societies, the NLA, the International Lipid Expert, the Canadian Consensus Group, everybody has tried to define statin intolerance. One thing is in common. One is everybody says that they must be intolerant to at least 2 statins, one of which must be in the lowest possible dose, and second, at any statin at any dose. Lowest possible dose of rosuvastatin is going to be 5, and atorvastatin is about 10 milligrams. The next thing that everybody says that the effect should be reversible, but also reproducible with rechallenge. And other known adverse events or adverse determinants should not be there, like, for example, the hypothyroidism. Now, what is statin intolerance? To combine all these things and put it in a nutshell, we will see that the statin intolerance is an inability to take statins to achieve goal LDL cholesterol due to muscle side effects or unacceptably elevated levels of liver enzymes or creatine kinase, failure to tolerate statin despite rechallenge, failure to tolerate at least 2 statins, one at the lowest dose and another at any dose, and absence of any factors that could provoke the adverse effects. They've also classified statins as partial and incomplete. If you're going to be complete statin intolerant, you can't take any statin. Partial, maybe if you can tolerate one of the other statins that we'll be looking at. There are 2 major abnormalities we spoke about. The first is the liver enzyme. I think take the easier one first, which is the liver enzyme abnormalities. And basically, it's a class effect, and it seems to be happening between 3 to 4 months after the initiation of statin therapy, which is about 0.5% with rosuvastatin and approximately 1% with atorvastatin. Of the different kinds, the commonest one is an asymptomatic elevation of aminotransferases, which happens in 0.1 to 3% of patients. Now, this seems to be dose-dependent, class effect, and may not be clinically significant. Clinically significant acute liver injury is very rare. Fulminant hepatic failure, there are sporadic case reports, and autoimmune hepatitis seems to be happening exactly in some case reports. But we need to know in practice that these can also happen, but although very, very rare. Now, the common disease that we find in clinical practice, the NAFLD and NASH. The Lipidization of India has come up with a statement already on this, and in that we have clearly mentioned that you don't have to worry if the patient is stable in all these diseases. You can start these patients on statins. And the number of patients who actually develop serious liver disease is 1 in 10 lakhs. That's very, very, very rare. But in routine clinical practice, 10 to 30% of patients do not receive statins because of fear of hepatotoxicity. Now, this we have to remember as physicians and try to avoid this factor. What about the routine monitoring of the SGOT, SGPT? Routine monitoring has been done away with by the FDA in 2012. So this is no longer required to be monitored in these patients. Next, we come to the crux, the most important reason, which is the statin-associated muscle side effects. Now, this seems to be the predominant cause, and there are several terminologies that have been used. The statin-associated adverse effects, statin intolerance, statin-associated muscle effects, statin-associated muscle symptoms. But today, we call all of them together as SAMs, or statin-associated muscle side effects. And in the crux of this is the creatinine kinase. We always attribute to creatinine kinase elevation. What is the elevation? How much of elevation? But we must remember that this is an unreliable marker of statin-associated myalgia, since it can also occur without elevation of CK. And CK can be elevated, confounded by several other age, sex, and ethnic factors. There are several other causes of CK elevation, like, for example, if you exercise, in a dose-dependent exercise can increase the CK levels. Drug interactions, genetic variations, coenzyme Q deficiency can itself increase this. Vitamin D deficiency has been associated with the CK elevations. So all these put together, what are the different types of effects that can be? This is an interesting paper by Turner et al., which showed that SRM0 or statin-related myopathy 0 is when there is an asymptomatic elevation of creatinine that is less than 4 times the upper limit of normal. This is seen in about 1.5 to 26% of patients, variable depending on, because different studies have used different statins and different kinds of things have been used. What about SRM1? Basically, there is a tolerable myalgia, but no statin shows a creatinine kinase elevation. Now, this has also been different at levels at 0.3 to 33%. What about stage 2? The SRM2 is the intolerable myalgia, wherein the CK level is elevated, but less than 4 times upper limit of normal. But this resolves completely on D challenge. So what about myopathy? Myopathy is when the CK levels are between 4 and 10, plus or minus muscle symptoms, but again, there is a complete resolution on D challenge. Severe myopathy and rhabdomyolysis are the next stage 4 and stage 5 ones. Now, this 4 is actually CK elevation more than 10 times, but less than 50 times upper limit of normal. Muscle symptoms are present because it's a myopathy, but there is also a resolution on D challenge. Rhabdomyolysis, you can have a more than 10 times elevation or a 50 times elevation alone, or if you have a more than 10 times elevation, you must have evidence of renal impairment plus muscle symptoms. Now, the last one is an autoimmune myositis, necrotizing myositis, which I will discuss separately later because of antibodies. Now, if you combine all these things together, you will notice that there is the rarity and severity keeps going up as the number from 0 to stage 6 goes up. Now, it's not actually staging. It is actually a gradation of this that could be said. So 0, 1, 2, 3, 4, 5, 6. As the severity increases, the rarity also keeps increasing, meaning clearly that this is not a very common finding. Most of the muscle effects seem to be happening because of the reduced synthesis of mevalonic acid. And this is because of the lower energy degeneration, and which may probably cause a muscle injury. But it's not as simple as that. Because if you look at it, there are several pharmacokinetic and pharmacodynamic factors. Pharmacokinetic factors basically increase the exposure of statins. Now, what is this? This is going to be a simple factor. What happens is in advanced age, female sex, low body mass index, there's increased exposures, comorbidities, several of them are there. You could have alcohol or kidney disease, liver disease, or you could have diabetes, hypertension, hypothyroidism, vitamin D deficiency. All these can increase the exposure. Some families see exercise-induced, grapefruit juice, higher statin dose. All these could be factors that could increase exposure. Apart from this, these pharmacodynamic factors, how the different statin acts and how these different statins are exposed, they produce the mitochondrial dysfunction, calcium uncoupling, and apoptosis and immune-mediated responses. All these could also lead to rhabdomyolysis, myopathy, and myalgia. Now, next, coming to clinically, how do you look at it? You look at patient-related factors, of which the important ones are advanced age, female sex, the small body frame, low body mass index, alcoholism, hypothyroidism, grapefruit juice consumption, excessive physical activity, and those with already some kind of a muscle disorder. Treatment-related, higher the dose, higher the effects, and concomitant drug usage, namely the fibrates, cyclosporins, macrolide antibiotics, amiodarone, and verapamil use. One word about the anti-HMG coviridectase necrotizing autoimmune myositis. Basically, there seems to be an existing pre-genetic susceptibility over which the statin seems to be probably the environmental trigger. The only reason why you should know is once you remove the statin, the myositis and the necrotizing feature keeps continuing. CK level does not come down, and treatment of this is going to be with immunosuppressant. So you must be aware of that such an entity is available. Clinically, SAMs or statin-associated muscle effects is going to be present if it is going to be bilateral, involving proximal muscles and happens within the first few weeks to months, basically within 3 months, and it resolves on discontinuation of statins. There have been several attempts to give clinical indices and clinical data, and of which the SAMS in the clinical index uses 4 particular points: location, basically meaning that if it's symmetrical, happening within 12 weeks, and within 4 weeks it's more, and resolution within about 2 weeks, the score is more, and what about re-challenge? So all these are taken into consideration, and based on this, what we have found out that you can have a probable, possible, or unlikely score. But basically, it's not going to be very difficult. I think clinically, you will be able to get it. The biggest confounding factor is the placebo, nocebo, or the drucebo effect. Basically, what is placebo? If you give an inert substance and it produces a beneficial effect, it's called placebo effect. But if the inert substance produces a harmful effect, it is called a nocebo effect. But when a drug produces more than expected benefits or more than expected harmful effects, that is a drucebo effect. Now, what happens is there is a predominant drucebo effect found with statins and muscle effects. The Ascot LLA had 2 arms, the blinded phase and the open phase. In the blinded phase, SAMS was noted in 2 and 2%, same amount in between the placebo and the statin. But once you opened and said the patient is taking statin, it increased considerably, 1.26% per year, where it was 1% per year for placebo. Now, in the similar Gauss trial, they also showed that patients were intolerant but put on atorvastatin 20 milligram or placebo. They again found out that 42% received a SAMS muscle symptom with atorvastatin. 26% developed it only with placebo. Now, this clearly shows that there can be a predominant drucebo effect or a placebo effect or a nocebo effect also. So even the placebo, if you suggest the patient, can start developing these kind of side effects. And those patients who are persistently intolerant, when you start giving a different drug like ezetimibe and evolocumab, again 20 and 28%, clearly showing that there is a predominant suggestion effect of this muscle-related side effect. And once you have these side effects, the major trial that came in last year was the Samson trial, which actually looked at patients who had discontinued statins within 2 weeks. And they gave patients 3 bottles, one with atorvastatin, one with placebo, and one empty bottle. And nearly about 60 patients participated, and 90% of the symptom burden elicited by statin was found in the placebo arm also. Now, in the follow-up of this trial, the NF1 trial, where 200 patients were studied, there's no difference in the muscle symptom scores between the placebo and the statin groups. Only 9% withdrew the statins or the placebo. Placebo was in 7%, 9% withdrew in the statin arms. And 2/3 of those, when they were given the results, actually restarted the statin. So if you tell the patient that it is not there, it seems to be working pretty well. So how do you treat these patients? Either you lower the statin, give an alternative statin, intermittent statin, low dose of statin, ezetimibe, and non-statin therapy. Now, how do you select the alternate statin? For which you need to know a little bit about the statins. There are different types of statins, basically the inactive lactones and the active acids. The active acids seem to be producing less of the muscle side effects. The inactive lactones basically are the lower statin and simvastatin. If you look at solubility, the water-soluble ones don't reach into the muscles and the side effects are a little less. Those are going to be the rosuvastatin, pitavastatin, and pravastatin. Again, if you look at the cytochrome P450, those that are not metabolized, the same 3 drugs, pitava, prava, and rosuvastatin, seem to be having less. So you can select a statin that is going to be not metabolized like these 3 drugs in these group of patients. And ultimately, the last goal is going to be to use alternative statin therapies like ezetimibe, the newer bempedoic acid, PCSK9 inhibitors, the bile acid secretins, and plant sterols. A lot of words have been said about the nutraceuticals, CoQ, the vitamin D, Redis, berberol, glucosamine. Now, all these drugs like the Redis, berberine, and the phytosterols can produce significant amount of LDL-C reduction. In India, turmeric has been tried. Basically, they contain curcuminoids and polyphenolics. Now, they've been shown to reduce muscle symptoms, but not been shown to reduce SAMS. So I just wanted to mention it in passing. So what is the role of these nutraceuticals? Very simple. These nutraceuticals are going to be useful as an alternative only in partial or complete statin intolerance, probably an adjuvant drug, but other than that, it's not going to be there. Vitamin D is used extensively in practice, and you will notice that vitamin D can induce CYP3A, and vitamin D supplementation reduces atorvastatin exposure. And actually, vitamin D has an inhibitory effect on HMG-CoA reductase, and low vitamin D3 levels can actually reduce the effect of statin. And vitamin D deficiency itself can produce myalgia and myopathy. And if you start giving vitamin D to patients on a re-challenge when the vitamin D levels are like statins seem to be better tolerated, but no proper RCT is there, probably that is going to be there. Now, I'll spend 1 minute on this particular slide, which is the Lipid Association of India's proposed treatment of statin associated muscle symptoms. Patients should have bilateral proximal muscle onset within weeks to months. And if you look at those patients with an elevation of less than 4 times, tolerable symptoms, continue statins. If you have either intolerable symptoms or between 4 and 10 times elevation of the CK levels, stop statins, reassess every 2 weeks, and if they are symptom-free for 2 weeks, restart either with the same policy, low dose intermittent different statin, or go to another group, another regimen if they don't tolerate it. If the patient persistently goes beyond 6 weeks, probably we'll have to be looking at other causes of this. If more than 10 times upper limit of normal, look at renal dysfunction. If there is a renal dysfunction more than 10 times, no statin, probably consult a nephrologist. If without renal dysfunction, again, comes to the left side, but in those patients with ASCVD, we ask you to exercise a little bit of caution, basically because more than 2 weeks, if you're going to expose the patient, not expose the patient to statin, the effects might be lower. So probably try to think about alternative statin therapy earlier. Now, when you look at the side effects, we have so far spoken predominantly about drug-related, patient-related effects, but there is a big doctor-related effect and media-related effects. WhatsApp sending messages that statins are harmful and all those things keep coming up. That and patient-related effects are pretty well known. Now, the doctor-related effects could be the fear of diabetes, the intracerebral hemorrhage, and all these other factors which do not have any significant evidence. And if you look at the new onset diabetes, clearly there is an increase in that. There are several mechanisms mentioned, and the increase seems to be dose-related and drug-related, maximum being with rosuvastatin 1.25 is the odds ratio if you use 20 milligrams rosuvastatin. But if you look at the HOPE-3 trial, you'll notice that the incidence of new onset diabetes is only 1.02, something to think about. And new onset diabetes happens only in persons with specific category of patients when the body mass index is more than 30, fasting blood sugar more than 100, or metabolic syndrome or HbA1c. So in these group of patients, if you try to avoid, you're going to avoid it and take more precautions, go for a lifestyle modification, you can avoid the new onset diabetes. The CTT has clearly mentioned that the risk of development is more than 50 times smaller than the absolute benefit in the CTT trial. Intracerebral hemorrhage, several meta-analyses have clearly shown it is not going to be beneficial. And though there is a slight increase in the incidence of intracerebral hemorrhage, actually the benefit seems to be much, much more because there is a significant reduction in the ischemic stroke with these patients. Now, this you must understand that the small vessel ischemia is the patient with that who's going to develop hemorrhagic stroke. And those patients really have 79% of coronary plaque and 39% stenosis. Now, these are the patients who are going to benefit most, and they should be treated with statin. Overall, to summarize what I have said, if you treat 10,000 patients for 5 years, 5 patients develop myopathy, 5 to 10 hemorrhagic stroke, 50 to 100 develop diabetes, but the number of events averted is 500 to 1,000. So statin intolerance basically is rare. Its inability to take statin to achieve LDL goals because of adverse effects or elevated liver enzymes or CK. And it is to be confirmed with a D-challenge and a re-challenge with statins. Commonest cause seems to be statin-associated muscle effects. There is a big placebo effect in this. Liver enzyme abnormality is very rare and routine monitoring is not required. New onset diabetes, the benefit is much more than the harm. Identify the risk factors for the diabetes and statin-associated muscle effects and exercise caution in these group of patients. Treatment, simple. Lower dose of statin, alternative statin, intermittent statin, and probably add up ezetimibe, and finally non-lipid lowering drugs. This is the algorithm that you must remember 4 to 10 times, and more than 10 times. Remember these 3 words when you start treating statin-associated muscle side effects. So finally, remember, doctor inertia is the biggest problem. Doctor inertia has to be overcome, and the ultimate goal, never ever give up for statin intolerance. Thank you very much for the patient listening. And dear friends, thank you so much. I would be very happy to take questions.